Welcome to this video where we'll explore frostbite, but not where you might expect. We're diving into the rare but serious condition of frostbite of the ear. While often associated with fingers and toes, the ear's exposed location makes it vulnerable to freezing temperatures, and understanding this condition is vital for anyone living in or traveling to cold climates. Frostbite of the ear, like any frostbite, is primarily caused by prolonged exposure to extremely cold temperatures. When the body is exposed to cold, it prioritizes maintaining core temperature, diverting blood flow away from the extremities, including the ears. This reduced blood flow, coupled with the direct freezing of tissues, leads to ice crystal formation within the cells, causing cellular damage and eventual tissue death. The pathophysiology of ear frostbite is a multi-step process. First, vasoconstriction occurs, severely limiting blood flow to the ear. As temperatures drop further, intracellular ice crystals form. These crystals rupture cell membranes, leading to cell death. Following thawing, a cascade of inflammatory events occurs, contributing to further tissue damage. This includes the release of inflammatory mediators, capillary leakage, and potentially, the formation of blood clots that further restrict blood flow, leading to ischemia and necrosis. While precise figures are difficult to obtain, frostbite of the ear is most common in regions with prolonged periods of sub-zero temperatures. Certain populations are at higher risk, including outdoor workers, the homeless, individuals with poor circulation, those under the influence of alcohol or drugs, and people participating in winter sports without proper protective gear. The incidence tends to increase during periods of extreme cold weather events. The signs and symptoms of ear frostbite vary depending on the severity. Initially, the ear may appear pale, waxy, or feel numb. You might experience a tingling or burning sensation. As the condition progresses, the ear can become hard and cold to the touch. In more severe cases, blisters may form after rewarming. These blisters can be clear or filled with blood. Eventually, if left untreated, the affected tissue can turn black and leathery, indicating necrosis or tissue death. Diagnosis of ear frostbite is typically based on a physical examination and a detailed history of cold exposure. The characteristic appearance of the affected ear, combined with information about the duration and intensity of cold exposure, is usually sufficient for diagnosis. In some cases, further investigations, such as angiography, may be considered to assess the extent of vascular damage, but these are not routinely performed. Ear frostbite is typically classified into degrees, similar to burns. First-degree frostbite involves superficial freezing with skin redness and mild pain. Second-degree frostbite presents with blistering. Third-degree frostbite involves freezing of deeper tissues and blood-filled blisters. Fourth-degree frostbite is the most severe, extending to underlying structures like cartilage and bone, resulting in significant tissue loss and potential amputation. Treatment for ear frostbite focuses on rapid rewarming in a warm water bath at a temperature of around 104 to 108 degrees Fahrenheit or 40 to 42 degrees Celsius for about 15 to 30 minutes. Pain management is crucial during the rewarming process. After rewarming, the ear should be gently dried, covered with sterile dressings, and elevated. Blisters should be treated according to standard burn care protocols. In severe cases, surgical debridement of dead tissue or even amputation may be necessary. Antibiotics may be prescribed to prevent secondary infections. Tetanus prophylaxis should also be considered. Prevention is key to avoiding ear frostbite. Wearing adequate protective gear, including a hat or earmuffs that fully cover the ears, is essential in cold weather. Avoiding prolonged exposure to freezing temperatures, staying hydrated, and avoiding alcohol and tobacco use, which can impair circulation, are also important preventive measures. Recognizing the early signs of frostbite, such as numbness or tingling, and seeking shelter immediately can prevent the condition from progressing. The prognosis for ear frostbite depends on the severity of the injury. First and second-degree frostbite typically heal with minimal long-term complications. However, third and fourth-degree frostbite can result in permanent disfigurement, hearing loss, and the need for reconstructive surgery. Recent research is focusing on the use of thrombolytic agents, such as TPA, to improve blood flow and reduce tissue damage in severe frostbite cases. These agents may help prevent the need for amputation and improve long-term outcomes. Further research is needed to fully evaluate the efficacy of these treatments.